Welcome to Knowledge on the Go, the podcast brought to you by the Vizient PI Programs team. I'm Maha Siddiqui, Performance Improvement Administrative Fellow at Vizient and your host. Workplace violence in ambulatory care faces unique challenges due to open access, isolated sites, and less immediate security resources. Joining me today to share their ambulatory care workplace violence prevention program success story is Jennifer Rodgers, Chief Nursing Officer at UCHealth, the University of Colorado Hospital. Jennifer, welcome, and thank you for joining us today.
Thank you. Thanks for having me.
Why is workplace violence different in ambulatory care compared to inpatient settings, and how was this program developed?
It's a lot different in the ambulatory setting for a couple of reasons. One, the sheer number of visits and the way that patients interact with the team. So a lot of ambulatory care is not only the brick and mortar in-person contact, it's also the electronic contact that our patients have with our teams and the telephone contact that our patients have with our teams. Verbal violence looks and feels different in the ambulatory setting because of the telephone verbal violence as well as the electronic incivility that has occurred.
Can you talk about how the program was developed?
The program was developed from listening to our frontline team. During the pandemic, ambulatory care nationwide turned upside down. The way that we deliver care quickly changed. For example, at our institution, we had about a 400% increase in My Health connection, so electronic messages, as well as telephone triage or verbal messages. From that, in listening to our teams, we learned a couple of things. What was occurring over the telephone and what was occurring over the electronic messages was really challenging. Our teams were being very distressed. Because of everything that was going on in the world, our patients were more stressed. And so not really having the tools to manage that is really how the elements of telephone and electronic messages really came to light. The other thing that we realized was in the ambulatory space, we also needed support at the clinic space when patients had significant challenges in how they presented, such as physical, verbal violence, and or assaults in the ambulatory space. From that listing, we really developed a program to support our teams.
Tell me more about your role as the Chief Nursing Officer and how it played into championing these initiatives.
My role as the Chief Nursing Officer in this was really to listen. The team did the work. The frontline teams always know best what the problems are and what the solutions are. My job is always to be a patient and staff advocate, and that's what I did. I helped take their ideas and plan, gain stakeholder buy-in and awareness, help break down barriers, and through data and stories, help tell what was really happening in ambulatory and to listen to a few of the phone calls and read the electronic messages. That's the best story of our why, to know that we had to do better for our teams and ultimately for our patients too.
Perfect. Let's discuss the interventions that are part of your program. Explain how BERT operates and the costs associated with it.
BERT stands for Behavioral Emergency Response Team. Think of it a lot like an emergency team. It's really derived from the concept of rapid response, which is a medical emergency response. The concept is it's either an in-person or virtual option, depending if it's on our main campus where we have our academic medical center, those clinics, it's in person, and then other locations, it's a virtual response. When a patient is having a situation that needs de-escalation or is getting challenging, the team arrives. In ambulatory, this team is comprised of a social worker. We have a security officer that arrives, and then it's a collaboration with the local and the virtual team. The concept and goal is to support the team, to support the patient and family, and trying to de-escalate. The really important part of having a social worker in the ambulatory space is different than an inpatient space. Once you've de-escalated, what do? You can't just say, now you're done in the clinic. The social worker then helps figure out what's the right disposition for that patient from the clinic. What resources do they need to have the best plan of care? It's evolved into what we call a pre-BERT response. These patients are coming back multiple times, and the teams can then plan to have the social worker there for a visit, or even sometimes the security officer, depending on the situation, to support the team and the patient if they're coming in for multiple ambulatory visits within a period of time. The cost is minimal. So we leveraged all of our existing resources, including our virtual behavioral team. They already are available. And on the off-site campus locations, they use the virtual behavioral health team to essentially do what I just described. The cost is 2.6 FTE of social workers, and that's the only cost. And the social workers have other things, such as social determinants of health, that they can focus on. So it's really a minimal cost for an impactful initiative.
And then you touched a little bit on verbal and telephone violence and cyber incivility are significant challenges. How has phone scripting and AI filtering helped manage challenging calls, and how has that impacted staff?
The scripting and decision algorithm that we have for telephone verbal violence has done a couple of things. One, it empowers our team to have the permission to know that workplace violence is not okay, particularly verbal violence in this case. They know that they feel supported by the organization and they have the ability to set boundaries and have a consistent method with our patients. It helps them de-escalate ultimately to support our patients in the care that they need, but doing it in a mutual respected way. If for whatever reason our patient's not at the moment where they can be de-escalated to what we need to do for a therapeutic plan, they have the ability to end the call. They have consistent follow-up, and then there's a process to loop back with the patient. It's been extremely empowering, and it really has helped our teams know how to better handle the situation and ultimately feel better at the end of that. In the situation of the electronic messages and cyber incivility, we're really in the early phases on that. AI helps filter the messages with keywords into a central location, and that helps those from initially coming to the frontline team. And then in a central location, we can work through those to either have the patient redo the message in a manner that's mutually respectful for our teams, or at least for someone to know what the message type is. So be better equipped to help either support those patients or, again, we can boundary set.
Was there any training involved for the staff?
Yes, there's a lot of training involved. And what's been remarkable, a lot of times people cringe when you talk about training. One more thing. And in this case, we had team members running toward the training. We've trained over 1,500 different staff members. This originally started for our nurses and medical assistants, and quite quickly we were getting outreach from all types of pharmacy, lab, our patient line who handles a lot of our centralized calls, wanting to get in on the training. That speaks to listening to the front line who knew how big of a problem this was, and also teams hungry to learn and train. It's ongoing training that occurs with everyone of the clinical team coming into ambulatory, and then we have ongoing updates.
That's wonderful to hear. For your last intervention, let's talk about the Conduct Review Board. How does the board operate, and what kinds of cases are typically reviewed?
The Conduct Review Board, it's supported at the highest level within UCHealth. The team meets 3 times a week. It's led by our system CMO. Our chief nurse executive is also part of that. And then we have other key stakeholders. And the concept is around meeting frequently to review cases so that we can systematically and with as little bias as possible support patients and have the right team members there to support their needs differently. They need different interventions. They maybe need a different plan of care. They need reminders as to how we just show up for each other, what a mutually respectful environment looks like between our patients and our teams. And then in rare instances, we determine someone may not be appropriate to have care within our organization. The concept is we really see great outcomes and we identify patients otherwise that are struggling or frustrated or need additional support that we otherwise wouldn't have known. Types of cases that are reviewed, we have some simple criteria. All of the cases come from our frontline team. Any employee, physician, or advanced practice provider can submit the concern. They give a brief detail, and the team interacts with that frontline team to learn more about the case. They always close loop with the frontline, which is wonderful. Types of cases, maybe someone that's having challenges with a chronic health condition such as pain or having some underlying challenges there. It can be individuals that are frustrated with how they can interact with the health team because they don't have the electronic options. They don't always have dependable transportation or ways to get in contact with the team. It touches patients that go throughout our continuum, trying to set those expectations. And then within the electronic health record, help all the team members be aware of what the plan is, what the challenges are, and hopefully what the solutions are. Because the same patients are going from a primary care or specialty visit to the emergency department that may get admitted to the hospital and then back into that environment.
For those tackling workplace violence in ambulatory settings, tools and resources are critical for success. What tools have you found helpful?
One tool is the triple ACN, which is the American Association of Ambulatory Care Nurses. They have an excellent toolkit on workplace safety. It outlines a comprehensive plan. That's probably the best resource available. Within that, some of the tools that we discussed today, including that telephone triage de-escalation algorithm. And then that links to resources, a lot of the major HRQ, IHI workplace safety tools.
This is great work with incredible results. Jennifer, thank you for sharing your insights.
Thanks for the opportunity to share the story. We're really proud of the work of the team, and we do hope it can help others and bring awareness to the unique challenges in the ambulatory space.
Our thanks to Jennifer Rodgers for sharing her story and program, and thanks to you for listening. From Vizient's PI Collaborative team, I'm Maha Siddiqui. Please join us for more knowledge on the go. Subscribe today, like us, and send us your comments at picollaboratives@vizientinc.com.